Hello, everyone, and welcome to RT Magazine's webinar on guiding asthma care with spirometry, FeNO, and oscillometry. This webinar is sponsored by Vitalegraph and Thoracis. Stay tuned for a message from each of them later on the program. Here's a look at today's panel. Today we have David A. Kaminsky, Dr. David A. Kaminsky from the University of Vermont College of Medicine. And I'm Mike Frattantura, the Chief Editor for RT Magazine. Thanks for joining us today. Here's just a look at our program today. Obviously, we started with the introductions. Then I'll introduce Dr. Kaminsky, and he's going to go through his presentation. And then we'll have some audience Q&A at the end of the program. We have a lot of time allotted for that. So before we start our program, I just wanted to pause for a message from one of our sponsors. Trusted by healthcare professionals all over the world, Vitalegraph delivers expert respiratory diagnostic solutions that are accurate and reliable, enabling you to make the best possible decision for your patient's health. For more information on how we can help you discover a true picture of respiratory function, please visit vitalegraph.com. And if you want, there's a little QR code on your screen there. You can scan that, or you can go directly to www.vitalegraph.com. So with that, I'm going to introduce Dr. Kaminsky. Dr. Kaminsky is the professor of pulmonary and critical care medicine at University of Vermont College of Medicine. He received his undergraduate degree from Yale University and medical degree from University of Massachusetts Medical School. He joined the faculty of University of Vermont College of Medicine in 1995 and continues to work as a clinician, researcher, and educator. Dr. Kaminsky, thank you for joining us today.
Okay, thank you so much, Michael, and thank you to RT Magazine and Vitalegraph for sponsoring this webinar. Again, my name is David Kaminsky. I'm at the University of Vermont in Burlington, Vermont, and I'm a professor of pulmonary and critical care medicine. And I'm pleased to speak with you today about the topic of using spirometry, exhaled nitric oxide, and oscillometry in the care of patients with asthma. Next slide, please. I do have a few disclosures that you can see here, none of which are influencing any of the points I'm going to make today. Next, please. So here are the learning objectives. Number one, I'd like us to understand the key role played by spirometry in making a diagnosis of asthma. Number two, examine how the exhaled fractional nitric oxide level can influence asthma diagnosis and treatment. Third, to explore the relatively new technique of oscillometry, although it goes back actually many decades in its origins. And we'll discuss briefly how it might supplement spirometry in making an asthma diagnosis. And then finally, through a series of cases, I'll try to illustrate how these three tests, spirometry, FeNO, and oscillometry, can enhance the care of our patients with asthma. Next, please. It's important to start off with a definition of asthma, and this is the Global Initiative for Asthma Definition. And basically, the key here is that asthma is a very heterogeneous disease. So even though there's chronic inflammation common to all patients, the symptoms vary from patient to patient, and most important, the lung function varies from time to time. And it's lung function that's variable over time that shows at least occasionally airflow obstruction that really defines the disease. Next, please. So on the left figure of a histology section from a patient who's healthy on the left-hand side, and to the right of that left-hand panel, you'll see a patient with asthma. And what you can see is that the airway lumen, which should be nice and open, is filled with a folded membrane of epithelium, mucus glands, mucus secretion, and the red color you see is a very enhanced smooth muscle that's built up over time. And you can see why the patient with asthma has difficulty breathing. They're trying to move air through that very, very narrow lumen. So that's what results in shortness of breath, airflow limitation or airflow obstruction. And the other key characteristic feature of asthma is airway hyperresponsiveness, meaning the airway is twitchy, or in other words, the smooth muscle is very sensitive to triggers that will cause it to constrict and cause abrupt bronchospasm. On the right-hand side, you can see a diagram that's illustrating pretty much our current thinking about the pathophysiology of asthma in terms of the immune response. When allergens or infections influence the airway starting up at the top, you can see there's a pattern of signaling between cells that results in our T cells, our T lymphocytes, secreting different mediators. And by grouping these into different groups, so-called type 1 and type 2, we realize that a lot of allergic asthma is type 2 related, meaning it activates cells like eosinophils and mast cells and basophils that cause an allergic type of response. And these cytokines and other mediators that are elaborated by the Th2 cells and these subsequent effector cells can result in smooth muscle constriction and mucus hypersecretion and edema and other features that enhance that airway narrowing that you see over on the left-hand side. Next, please. So when we're making a history, we're trying to figure out, okay, what does this patient have based on their symptoms? And we know what asthma is in the back of our head in terms of what the cells look like and some of the signaling and so forth. So the first thing we'll consider is, well, does their history fit? And the typical 4 symptoms that people describe are wheezing, shortness of breath, chest tightness, and cough. But the thing is, again, that they can vary over time and vary in intensity. We look for daytime versus nighttime intensity. We look for various triggers like exercise or allergens. And these are the kind of features that help us support a diagnosis of asthma based on history alone. Next. But the key to making the asthma diagnosis is measuring lung function. And as you know, FEV1 is the most robust measure of lung function that we have that's been proven reliable over many, many decades. And the FEV1 is the key to the asthma diagnosis because when we look at FEV1 in relation to FVC, that's how we make the determination of whether or not there's airflow obstruction. A low ratio indicates airflow obstruction. And then in terms of this variability over time, different ways are available to see that. One is simply measuring FEV1 over time and seeing how much it varies compared to a person without asthma. Or we could even measure peak flow in the same regard and see that it has excessive variability over, let's say, a span of 2 weeks compared to a person who doesn't have asthma. That variability in peak flow in adults has been quantified as being more than 10% compared to the mean value. Now, FEV1 can be done the same way, or in the laboratory, we could give a bronchodilator and see if the patient has some degree of airway responsiveness by reducing their airflow limitation and enhancing their FEV1. And as most of you are probably aware, the ATS-ERS just came out with a new technical standard that's suggesting that such a response be considered significant if there's more than a 10% increase in the predicted value of the FEV1. The other way we can judge variability is looking at exercise challenge testing or methylcholine challenge testing. So these are all ways to try to document not only the airflow obstruction is present, but airflow obstruction is variable over time. Next, please. So what is the FEV1? Of course, John Hutchinson first described it back in the 1800s. There's a lithograph of him on the left-hand side with an ancient water-sealed spirometer that he's blowing into. The FEV1, of course, is the amount of air that's been expired during a forced exhalation in the first second of the exhalation. And we relate that to the total amount of air, the forced vital capacity. And it's the ratio that determines whether airflow obstruction is present. You can see the volume time curve on the top, defining those two measures. And on the bottom, if you plot flow against volume, you can see the FEV1 occurs about 3/4 of the way down from TLC towards RV. That's how much air comes out in the first second. It takes about a second to empty the lung across that volume distance. Next, please. On the left-hand side is the patient who has classic airflow obstruction by spirometry, a low ratio. And I'm defining low by the lower limit of normal of the z-score being less than -1.64. As you know, GOLD likes to define it by a fixed ratio of 0.7. There are advantages and disadvantages potentially to both definitions. On the right-hand side, don't forget that spirometry can also indicate when restriction might be present, and we suggest restriction when we see a low vital capacity in the presence of a normal FEV1-FVC ratio. Next, please. The new interpretation strategy that I mentioned was published in ERJ in 2022. On the left-hand side, there's the new definitions of bronchodilator response and severity of lung function impairment, with, again, emphasis on the percent predicted for the bronchodilator response and the z-score for the severity of impairment. On the right-hand side is a simplified algorithm on how to assess spirometry, starting with the ratio, and then looking at the ratio, whether it's normal or abnormal, and then looking at the vital capacity and whether it is normal or abnormal. And you can classify different forms of spirometric impairment based on this simple algorithm. Don't forget that when the vital capacity is low, there are many reasons for this, including airflow obstruction. And in those cases, you really need to measure lung volumes to sort out better what the cause of a low vital capacity is. Next, please. So let's consider a patient here. This patient has airflow obstruction as seen by a low ratio of FEV1 to FVC. These data are old and I didn't convert them to Z-scores, but no one would disagree that an FEV1 FVC ratio of 54% or 0.54 is low for anybody. After bronchodilator, you can see that the FEV1 improved a full liter from 3.18 to 4.18, or a 31% improvement. And again, by any definition, this would meet the criteria for a significant bronchodilator response. Below, I show the old definition of 12% and 200 ml increase in FEV1 or FVC, but then remind you of the new definition, which is a greater than 10% increase of the predicted value. In this case, the patient's predicted value was 4.68. 10% of that would be 0.468, or 468 milliliters. And we want to see that amount of improvement. And in fact, this patient had 1,000 milliliter improvement. So there was a significant bronchodilator response here. Next. Here's a question for you. This is a 65-year-old patient, non-smoker, lifelong asthma. The question is this really asthma? So if you look on the left-hand side, pre-BD stands for pre-bronchodilator or baseline. The actual values of FEV1, FVC, and the ratio are given in the first column. And you can see the lower limits of normal and the Z-score in the middle columns. And you can see that the ratio is quite low at 38% compared to a lower limit of 65%. So there's no question this patient has airflow obstruction. On the right-hand side, post-BD, post-bronchodilator, you can see the response to albuterol. And I think everyone would agree there's really a very little response here. So the question is this asthma? We're all taught that asthma has reversible airflow obstruction. Next, please. I would argue that this is asthma. It's a patient who doesn't have a bronchodilator response, probably because, and he is a real patient of mine, he's had very poorly controlled asthma for many, many years, and he likely has a lot of airway remodeling and scarring such that he can't respond to bronchodilator anymore. So this has been dubbed asthma COPD overlap. It's quite confusing what this really represents. In my mind, this is one definition of asthma COPD overlap, someone who clearly has asthma, but fails to bronchodilate anymore. And so they've developed a more chronic pattern of obstruction. Next, please. Don't forget, when we do spirometry, and spirometry is key to making an asthma diagnosis, we get more than just the FEV1 and FVC. We also get the flow volume loop. And I can't emphasize enough how important it is to look at the shape of the flow volume loop. On the top, we're all familiar with the shape that we see in variable intrathoracic obstruction, such as asthma. And on the bottom, you see the shape where the expiratory flows are normal, but the inspiratory flows are reduced or irregular. And this is the pattern that's classic for variable extrathoracic obstruction. For example, vocal cord dysfunction could look this way. And in the middle, you see the pattern of so-called fixed obstruction, where whether the obstruction is intra or extrathoracic, if it's fixed structurally, that means it doesn't vary with inspiration and expiration. You're going to see flattened flows on both inspiration and expiration, giving you that rectangular shape. Next slide. So consider this patient, who is a long-standing patient of mine. She's 45 years old. She's had multiple exacerbations over many years of her asthma. She's been intubated in the past. We've had to use Heliox and CPAP on her multiple times. She really has very poorly controlled asthma. She has a lot of stress at home. Also in her job, she works full-time as an EMT, and you can just imagine the stress involved with that type of occupation. She's on inhaled steroids and long-acting beta agonists and long-acting muscarinic antagonists and leukotriene antagonists and theophylline and xylitol, and she still struggles. And if you look at her flow volume loop over towards the right, you can see that it's relatively flat on inspiration and not so great on expiration either. Her chest x-ray lower right is pretty unremarkable except for maybe low lung volumes. But what we saw when we did laryngoscopy on her during a period of exacerbation is that her vocal cords were closing during inspiration. That photo you see is her trying to take a breath in when the vocal cords should be open, and you can see that they're nearly completely shut. So this is an example of vocal cord dysfunction that's exacerbating asthma. And the hint really came not just from her history, but also from the flow volume loop. Next slide. Here's another patient we saw in clinic a few years ago. She was dubbed as having asthma because she's only 22 years old. She's short of breath. She's a lifelong non-smoker. She had airflow obstruction on her spirometry, as you can see, but no one really paid attention to her flow volume loop. And you can see the flow volume loop towards the right-hand side over there and the volume time curve, and you can see it's very flat on both inspiration and expiration. And when she had laryngoscopy, next slide, you can see that she had granulomatous inflammation of her larynx. And if you go back one slide, this was granulomatous polyangiitis, a connective tissue disorder involving inflammation and vasculitis that can involve many different tissues in the body. In this case, her larynx was involved. Now pay close attention to that flow volume loop, the flattened shape, and go ahead 2 slides now. And that's the slide showing her flow volume loop after she had laser therapy to open up that larynx and relieve some of the granulomatous obstruction. You can see how the loop is greatly opened up back to a normal shape. And if you look at her spirometry, now she no longer has obstruction. So this wasn't asthma. This was a structural lesion of the vocal cords, again, picked up when someone paid close attention to the flow volume loop. Next slide. Now, here's a patient who, if you focus on the spirometry at baseline, her numbers are normal. I'm only giving you percent predicteds here. And if you look at her lung volumes down below, her lung volumes are normal, and her airway resistance is also normal. So she presents, however, with chronic cough, and the question is, what can we do next? We gave her bronchodilator, and there was no significant response. So the next step is you can try to provoke bronchospasm by giving her methacholine, and that was what was done. And you can see on the right-hand side, at a dose that was well below 8 milligrams per ml concentration, and this test was done some years ago before the new guidelines came out, you saw that she had a 66% drop in her FEV1. Notice also, by the way, she became very hyperinflated and trapped a lot of gas with her residual volume going up 70%. And her airway conductance fell 75%, nearly so, indicating a very high increase in airway resistance. So next slide. So what we've done here is give her a methacholine challenge, and you can see again at the 1 milligram dose, she markedly dropped her FEV1, which is compatible with a diagnosis of airway hyperresponsiveness, indicating in the right clinical context that this would be compatible with asthma. And on the right, you can see the dose response curve of someone who's normal. If you look at their FEV1 in red against higher and higher doses of methacholine, it's pretty flat until you get to quite high doses, and then even the normal person will bronchoconstrict. But the person with asthma, who's shown in blue, constricts at a much lower dose and to a much greater degree than the person who's normal, and that's why it's called airway hyperresponsiveness. Next, please. And this is just to show you in graphic terms what happened to her flow volume loop. In red is her baseline, in green is after methacholine, and in blue is after bronchodilator was given after the methacholine to show how the response was nearly completely reversible. Next, please. And finally, I mentioned the new guidelines that were published in 2017. We're no longer thinking about methacholine challenge in terms of concentration, but rather the dose of methacholine that causes the response. And these just give you the suggested cutoffs for dosing on the left-hand side versus the old concentrations in the middle, and the interpretation of such a response on the right-hand side. So we now consider someone who doesn't respond to methacholine at a dose greater than 400 micromoles as being normal, whereas someone who responds below 100 micromoles is having airway hyperresponsiveness. And in between 100 and 400 is a so-called gray zone or borderline zone. Next, please. Finally, with regard to spirometry and asthma, it's important to remember that, quote, all that wheezes is not asthma. That was Chevalier Jackson, a physician in the 1800s who first invented rigid bronchoscopy, who reminds us of this very, very important lesson. And you can see in both adults and children, there are many, many things that cause wheezing. So just because someone wheezes doesn't mean they have asthma, and it's important to put together the entire picture, including the spirometry. Next, please. So I want to show you another case here of a patient who's 55, lifelong non-smoker, diagnosed with asthma for many years. She was treated with inhalers, steroids, bronchodilators, nothing was helping. And notice her spirometry. It's not obstructed. In fact, it looks restricted. Now, we can't prove that without a TLC, but certainly the pattern is compatible. Next slide. So this is a case that demands further investigation. On the left-hand side, we got lung volumes on her, confirming that she was restricted, with her TLC being 72% of the predicted value, and her diffusing capacity was normal. Now, during imaging, we obtained inspiratory and expiratory CT images, which you can see on the right-hand side. And what we see here is a large degree of air trapping. During expiration, you expect the lung to go down to a more gray, homogeneous pattern. But instead here, if you look carefully, you can see regions of dark black, which are areas where air has been trapped in the lung. Now, people with asthma can have this, but this patient doesn't seem to have asthma by PFTs. So we have to start thinking out of the box, what else could this be? And in fact, the radiologist thought this could be compatible with constrictive bronchiolitis or possibly chronic hypersensitivity pneumonitis. Next slide. So in this case, we actually got a surgical lung biopsy and we diagnosed constrictive bronchiolitis. This is a disease of the small airways where they become narrowed and scarred. And lots of things can lead to this, but it's not asthma. And in fact, there's really no good treatment. Macrolide antibiotics have been tried to slow this down. But in fact, next slide, we ended up referring this patient for lung transplant evaluation. And she is deemed a candidate for lung transplant, but luckily I've been following her for many years and her lung function has remained stable. So she had some type of insult, whether it be a viral mediated infection, an exposure, something that caused lung injury and damage to her small airways. And thankfully it seems to have stopped, because for many years now, her lung functions have remained normal. Nevertheless, we keep her on azithromycin, and she does require prednisone every once in a while for an exacerbation, which does seem to help, but inhalers don't help her symptoms at all. So again, pay attention to spirometry, the shape of the curve, the numbers in the right clinical context. That's how we have to really interpret the results. Next, please. Now, spirometry is not a perfect tool. As much as I like it, and I've told you about its advantages, it's not great. It's hard to do for a lot of people. There's still disagreement about what the lower limits of normal should be. And it's very gross measure of airway function. It tells us how much air was expired, but it doesn't really give us a lot of insight into why. So next slide, please. First, I want to talk about another measure which has been advocated to help us in the evaluation of asthma beyond spirometry, and that's fractional exhaled nitric oxide. Next, please. So many years ago, 1993, in the ERJ, the group in London published this very, very important paper that showed in patients with asthma, they had higher concentrations of nitric oxide in their exhaled air compared to patients who were healthy. And you can see in the graph down below there, over time, the amount of exhaled nitric oxide that was coming out in these patients far exceeding the normal values shown down below in the dotted line. Next, please. So what is nitric oxide? Nitric oxide is a very small molecule. It exists in all the tissues in the body. It's thought that it's got both pro and anti-inflammatory properties, and it has many other properties as well. In fact, it's also a signaling molecule. And what I've tried to show you in this slide, which is a little bit complicated, but if you kind of focus at the middle top there, where it says lumen, that's the airway lumen, and the pink is the airway epithelial cell. What's happening here is various agonists or irritants or inflammation can cause enzyme changes within the epithelial cell that result in the formation of nitric oxide. Now, if you go on the left-hand side where it says CNOS in green, that's the enzyme that makes nitric oxide at a low level all the time. And this nitric oxide is thought to be important in bronchodilation and bronchoprotection and has some anti-inflammatory effects. If you go over to the right-hand side in red, where you see the square that's labeled iNOS, that's inducible nitric oxide synthase. That's the enzyme that's upregulated in a response to infection or other irritants, and their nitric oxide is also made. And here, the nitric oxide is probably being made in a type of defense mechanism, trying to fight off infection or other type of injury. But the problem is the nitric oxide itself can be very injurious and can cause what's called nitrative stress. And that results in damage to molecules in the cell that can result in cell dysfunction and, among other things, airway inflammation and airway hyperresponsiveness. So maybe it's no surprise that asthmatics make more of this molecule, and you can detect it in their exhale breath. Maybe they make more of it because of the left-hand side of the equation, where they're trying to protect their lungs against bronchoconstriction, but then they make more of it too on the right-hand side of the equation because they're being irritated by various triggers. And so the nitric oxide really has dual properties. Next, please. So what's interesting is, as shown in the first two columns, control and untreated asthmatic, nitric oxide is higher in these untreated asthmatics compared to controls. But if you treat these asthmatic patients with inhaled corticosteroids, you can bring the nitric oxide levels way down. And this probably has to do with the nitric oxide, with the inhaled steroids directly interfering with that enzyme iNOS that generates more nitric oxide. Next, please. There are multiple ways to measure the exhaled nitric oxide, and I'm not going to go into any details, but chemiluminescence and electrochemical means are the main ways that this is done. Right now, there are a lot of portable sensors out there that are used throughout the world that work on an electrochemical basis, and that's the kind we have in our laboratory here. You can also measure this through various laser methodologies as well. Next, please. Now, measuring nitric oxide, when it was first discovered and first published, people realized that there's a lot of methodology that's critical to doing it consistently and reliably across patients. So there were guidelines published in 2005 for recommended standard procedures. And some of the key points here are that when someone exhales, you want them to have a plateau, steady flow of gas to measure the nitric oxide. And one important thing is if you measure nitric oxide from the mouth, it can become contaminated with nitric oxide that's made in our sinuses. Our sinuses make a lot of nitric oxide. So to exclude the sinus gas, it was discovered that if you breathe out against a known resistance, this will close the soft palate and exclude nitric oxide coming from the sinuses. So you're really measuring it primarily from the lower airways. So when you do this test, you breathe out against a resistance at a steady state. And if the machine detects a sufficient exhalation, it's then able to give you a nitric oxide reading. We want to obtain at least two readings that agree within 10%, and usually the mean of the two readings is reported. Next, please. Now, how's FeNO or FeNO used in asthma? In many different ways. This was a nice review recently published in the journal Diagnostics that tells us about the diagnostic ways nitric oxide is used. And right now, guidelines suggest that if the exhale level is greater than 50 parts per billion, that's consistent with eosinophilic inflammation. Whereas if it's less than 20 parts per billion, that's probably a normal range. And once again, like so much of lung function testing, there's a gray zone between 20 and 50. If you look on the right side, patients who have higher nitric oxide levels are predictive to respond to inhaled corticosteroids. And likewise, if someone says they're taking their steroids and they're not reducing their nitric oxide levels, you can use this as a form of measuring compliance with therapy or maybe improper technique. That could be going on as well. In the lower left, it turns out that higher nitric oxide levels do correspond to worse asthma control and increased risk of exacerbations of asthma. So it can give some prognostic information. And finally, there are a lot of confounders to consider. And one of the biggest ones is, of course, atopy. If someone is allergic, they may have high nitric oxide levels, but not have asthma. And also the levels will rise with typical viral infections. There are certain foods, too, that can elevate the nitric oxide. For example, beet juice or kale. Next, please. The Global Initiative for Asthma has made some recommendations about how we should be using nitric oxide, and they suggest it's used to guide treatment in children. Whereas the NIH expert panel report has suggested there's conditional evidence for using it to help with diagnosis, as well as to help guide treatment, perhaps in children with the best evidence. I'll go through a couple of these in a second. Next, please. And this is a little bit complicated algorithm that was just published in Chest last year that kind of guides us as far as how we should use nitric oxide. So just to go through this briefly, starting in the upper left, you have someone who's not diagnosed with asthma and is not on inhaled steroids, and you measure nitric oxide level. What you can say is if their level is greater than 50 parts per billion, then it's likely they have eosinophilic inflammation. And if you really think this is asthma clinically, then you probably on good grounds to start them on a trial of inhaled corticosteroids. If that person, though, has a very low nitric oxide level, you haven't excluded asthma, but you've probably made it less likely. And it's important to at least think about what else to consider as far as other diagnoses like vocal cord dysfunction or constrictive bronchiolitis, as I mentioned, other things that can cause wheezing and an asthma-like presentation, but aren't actually asthma. Now, once you've made the diagnosis, if you move to the yellow box in the middle, you can again look at the nitric oxide levels periodically to help with further management. For example, if you go all the way to the left and the nitric oxide levels remain very high, if that person's asymptomatic, then maybe you've got good control with the inhaled steroids, you could cut the steroids down. Excuse me, I'm mixing up the green on the right. Sorry about that. If the nitric oxide level is still high and they have no symptoms, you got to think of what else could be going on. But if they do have symptoms, you might want to even increase the dose of steroids or again, consider other exposures or irritants that are driving the asthma. Moving all the way to the right, which is what I meant to say, if the patient has asthma and they have a low nitric oxide level, they may be responding well to treatment if they have no symptoms, and you can consider dropping the steroid dose down. If they are still having symptoms, then again, you want to try to think about other conditions that could be contributing, not just asthma itself. Finally, in the middle, here we are once again in a gray zone, greater than 20, but less than 50 parts per billion. If that patient has no symptoms, you might want to continue to observe them carefully and repeat some measurements. But if they are having symptoms, either consider further diagnoses, make sure they're using their inhalers properly, or consider increasing the inhaler dose. So these are ways in which the exhaled nitric oxide can help you manage the patient with asthma and maybe titrate their therapy. Next, please. I want to share with you an old study that was first to suggest that we could use nitric oxide in titrating therapy. This was a study that was published in the New England Journal looking at 97 patients with asthma who are on inhaled steroids, and the dosing was going to be adjusted either by following current guidelines or using their nitric oxide level. The guideline group was on the left-hand side. You can see based on their symptoms, their nighttime awakenings, how much albuterol they were using, and so forth, you could figure out whether they were controlled or not, and you might adjust their inhaled steroids. The FeNO group was based on whether their exhaled nitric oxide was less than or greater than 15 parts per billion. That was because at the time they used a slightly different methodology such that 15 was the cutoff. And then in the box on the right at the top, you can see how they adjusted the dosing based on whether asthma was controlled or not controlled. If not controlled, they would step up in dosing in terms of inhaled steroid dose. If they were well controlled, they would step down and so forth. And at the end of the study, in 12 months, they compared outcomes. Next, please. What they found on the right was that there was a 45% reduction in exacerbations in the FeNO group, but this did not reach statistical significance. Now, you can always argue maybe the sample size wasn't large enough, etc. But obviously there was some effect, I think you can say. And on the left-hand side, you can see also when they compared the fluticasone dose in different ways, they found that at the end of the day, the group that was being managed by FeNO levels actually used less steroids. So this was an argument that using FeNO might be a way to reduce the exposure of patients to inhaled corticosteroids, which is a good thing. Next slide. The other way that FeNO might help is if you're trying to differentiate COPD versus COPD with asthma overlap, or a so-called ACO, asthma COPD overlap. And this is just one study of many that have been published that showed that in the patients who clinically were felt to have an overlap, you can see in the light gray bars that their exhaled nitric oxide levels were higher across different categories compared to those who just had COPD. So FeNO can help you if you're really trying to sort out if there's an asthmatic component to someone's COPD. Next. Once again, I have to remind you, though, that seeing an elevated or a reduced FeNO level is not just specific for asthma, but can be seen in other diseases as well. In fact, some COPD patients do have elevated FeNO, probably because they have an eosinophilic component. Cystic fibrosis patients and patients with primary ciliary dyskinesia actually can have very low levels. And we know smoking, by the way, will reduce FeNO levels too. Patients with allergic rhinitis can have elevated levels. And you can see different categories of disease listed along the left-hand column that can result in different levels of FeNO seen in the first column to the right of that. The other columns just represent nitric oxide coming from different compartments in the lung. That is to say the airway versus the alveolar region, and there are ways to sort that out. But using that specificity hasn't really made its way to clinical practice yet. Next slide. So I do want to share another case with you. This again is one of my own patients, Mr. T, who I've known for many years. He has severe cough and shortness of breath. He's a lifelong non-smoker. And as you can see by the spirometry, the FEV1 FVC ratio was 0.61, which is low. 0.65 was the lower limit of normal for a man his age. And he appeared to have a tremendous bronchodilator response. But I think you can see by the shape of the flow volume loop on the left and the volume time curve on the right, I was not that convinced that his technique was very good with spirometry. In fact, he was coughing all the time, and spirometry became very unreliable. So I needed another way to evaluate him, especially because he had a lot of workplace exposures, and he was applying for disability. And the disability physician insisted on spirometry and methacholine to diagnose his asthma. And I had to push back and say, but he can't do spirometry, and therefore he can't do methacholine. So next slide, please. What we did is we measured his exhaled nitric oxide level, and it came out at 56 parts per billion. And I was able to make the argument that given the type of exposure he had, his symptomatology, and this nitric oxide level, that I felt this was strongly work-related asthma. And I did put him on treatment, and he got much better. And he did succeed in getting disability benefits. So this was just one example in my own personal practice where I found the fractional excretion of nitric oxide, or FeNO, was very helpful. And this being the case of a patient who just couldn't do spirometry. You can imagine children who might have trouble with spirometry, or any adults that might have trouble with it too, where FeNO might supplement or serve as another diagnostic measure to help you in making the determination of whether the person may or may not have eosinophilic inflammation, and therefore may or may not have asthma. Next slide. Here's a few more examples, how to use FeNO. This was a 13-year-old girl who had cough and shortness of breath, normal x-ray, normal exam, normal spirometry. Her FeNO was 23, so it was kind of just above the normal limit, but in the gray zone. We did an exercise challenge on her, and she had a substantial drop in FEV1, clinching a diagnosis of exercise-induced asthma, and she did well with treatment. So the FeNO here, being slightly out of the normal range, really pushed us to pursue this further and get the exercise test. Next, please. Here's another example of a 61-year-old man who carries a diagnosis of moderate persistent asthma with daily symptoms, and he's been on good treatment, and his FEV1 FVC ratio is very low. There's no question he has asthma, and his FeNO, despite being on treatment, was 74 parts per billion. And in his case, we realized he wasn't adherent to therapy. He didn't understand how to use his inhaled steroids. He wasn't using them properly. He wasn't using a spacer, for example. And there were a lot of confounding factors going on. For example, in his case, as I recall, he had a lot of gastroesophageal reflux that was uncontrolled. So we were able to use the high FeNO level to tell us that, okay, this is asthma, and he's on the right treatment, but something's wrong here. And so we pursued it further and was able to help him control his disease much better. Next, please. And finally, here's someone, another example, 74-year-old woman, cough and dyspnea on exertion, strong history of asthma and allergies as a child, but a heavy smoking history. Now, her spirometry showed airflow obstruction, and she did have a significant increase in her response to albuterol. Excuse me, she did not have a significant increase, but albuterol did help. And the question was, is this asthma or COPD? And we weren't quite sure. So in this case, another FeNO level was obtained, and it was very high. So we felt confident labeling her as an overlap of asthma and COPD. And the key point here is that when you make that diagnosis, you treat the patient as if they have asthma. In other words, you start with inhaled corticosteroids. The inhaled steroids play much more of a role than they do in COPD alone, where inhaled steroids aren't added on until someone is more severe or having a lot of exacerbations. Next, please. So the ATS came up with a so-called single question, and their single question was, how do we deal with exhaled nitric oxide? And they came up with this recommendation. In patients with asthma in whom treatment is being considered, we suggest the use of FeNO in addition to usual care, rather than just using usual care alone. And basically, if you look at this diagram here, based on whether the FeNO level is low versus high, and based on whether the patient is having a lot of exacerbations or not, it gives you a similar type of algorithm as the chest chart did that I showed you before, where you might step therapy up or down, or consider alternative diagnoses and so forth. So the ATS is suggesting that FeNO be used to help us when we want to treat someone with asthma, and we really need a bit more information to help guide therapy. Next, please.
Traditional methods often miss underlying insights on patients' small airways disease progression and have difficulty obtaining measurements on pediatric patients. The TremoFlow C100, harnessing airwave oscillometry technology from Thoracis, emerges as the missing piece in rapid lung function assessment and monitoring. AOS measurements are made during a patient's normal tidal breathing and can be used in both pediatrics and adults frequently for ongoing monitoring, small airways assessments, and treatment evaluation. To learn more, visit www.thoracis.com.
Thank you, and I appreciate the support of Thoracis. That's a good segue. Basically, they're offering a device that can help us measure airway function in a different manner than spirometry, and we're going to get to that, which is oscillometry, in just a moment. Okay, we're now going to enter our final phase of the three measures we're going to talk about, and we're going to talk about oscillometry. And this is a diagram from a recent publication that basically said, okay, how else work on making a diagnosis of asthma if it's not straightforward? And they suggest looking at more history, such as atopic history, allergies, looking at important patient outcome measures, considering methacholine challenge, etc. But here's where they mention not only spirometry and exhaled nitric oxide, but oscillometry as a diagnostic measure. Next. So what is oscillometry? Oscillometry is a technique also known as the forced oscillation technique, wherein someone sits on a mouthpiece as shown in that upper right-hand figure, and they breathe quietly. And while they're breathing, there's a loudspeaker or other generator that's putting a signal into their lung, usually an oscillating signal that can be at one frequency only or multiple frequencies at the same time. And it can be generated by different mechanisms, either a speaker or a diaphragm that's pinged, or a piston that's moving back and forth very quickly. Next, please. And again, in diagram form, you see the person on the left-hand side, in this case, breathing on a mouthpiece with a speaker generating a signal. And we get two components out of the signal, pressure and flow. And then we modulate the pressure and flow signals to come up with an in-phase component of the ultimate signal that's emitted, which is the pressure that's in line with flow or in phase with flow, and that's the resistance of the respiratory system. And then there's also an out-of-phase signal that comes out of this, and that's called the reactance. Next, please. And so again, if you look on the left-hand side, there's the pressure oscillating up and down as the person's breathing with the superimposed signal, and there's the flow moving in and out as the person is breathing with the superimposed signal. And using some complex mathematics, a technique called the Fourier transformation, you come up with these two components, resistance and reactance. Now, resistance is capitalized R, RS stands for respiratory system. Reactance is abbreviated with the letter X, So XRS represents reactance of the respiratory system. And when you plot these against frequency, you see curves over on the right-hand side, sometimes called an oscillogram, to be, parallel to spirogram. Next slide. Now I'm going to go through piece by piece what all of this means. So bear with me here. Overall, what we measure with oscillometry is something called impedance, respiratory system impedance. Impedance refers to the total force that has to be overcome to move this oscillating signal in and out of the lung. And this force has to do with resistance of the tubing, that is the bronchial tubes and the airways, elastance of the parenchymal tissue, the elastance and resistance in the tissues themselves, including the chest wall, and even some inertance, that is to say, moving the mass of gas in and out at different frequencies. When you sum all that together, you get one number, and it's called impedance. But it's more useful to break the impedance down into its components of resistance and reactance, like I just talked about. So if you look at the top, you see the resistance curve, and it curves from a little bit of a higher value to a lower value as you go across in frequency. And the arrows show you the resistance at 5 Hertz and the resistance at 20 Hertz. The resistance refers to the frictional losses that occur due to airflow as well as tissue flow. So the tissue, don't forget, is rubbing against each other as well, and there's heat generated, and that comes up as the resistance. The lower frequencies are more sensitive to more distal lung events, like 5 Hertz. The higher frequencies are more sensitive to proximal lung events, like 20 Hertz. If you see a difference between 5 and 20 Hertz, that's called frequency dependence, because the resistance is dependent on the frequency at which you're measuring it. And that signifies that you have a lot of heterogeneity in the lung in terms of the resistance. Now, a lot of people say that this refers to small airways, but it doesn't reflect only small airways. It can reflect large airway heterogeneity as well, so be careful of that. Now, the reactance is shown by the dotted line that you see a little below the resistance curve. And this refers again to the elastance or stiffness of the lung and the chest wall, as well as the inertance of gas. Now, luckily, the inertance doesn't come into play until you get to pretty high frequencies. So we mainly think of the reactance as reflecting the elastance or the recoil of the lung tissue. Luckily, also, the chest wall doesn't play a big role in this at most frequencies. So we're really looking at lung stiffness. Now that curve at 5 Hertz starts off below 0, as you can see, and then it rises and crosses the x-axis. It's called the resonant frequency, or FRES. The resonant frequency is where the resistance and reactance are balanced out with each other, and the impedance is now 0. Below that resonant frequency is where the elastic component predominates, and above that resonant frequency is where the inertance components predominates. But again, we almost always deal with the elastic component. Finally, there's another feature here, which is that shaded blue triangle, AX. That's called the area under the reactance curve. And it's just another way of depicting what's happening with the reactance. We'll go over this in a second. Next slide, please. So I want to show you what these curves look like in a healthy person above and a COPD patient down below. In the healthy person, there's not a lot of heterogeneity, so the resistance curve is pretty flat with frequency, and the reactance curve has a slight upward slope, and it crosses the x-axis at around 8 Hertz. That's where the elastance and inertance exactly balance out, and the impedance is only represented by the resistance at that point. And you can see a normal resonant frequency in a healthy person is around 8 Hertz. Now down below is the patient with COPD. Notice their resistance overall is elevated. There's more curvature, meaning there's more heterogeneity in their airway tree. And notice that their reactance curve is shifted to the right and down somewhat, such that the AX, I don't show it here, but that area under the curve is greater. The resonant frequency is shifted way over to the right, in this case about 22 Hertz. That's what happens when you have airways that are resulting in COPD, a lot of heterogeneity, a lot of narrowing, a lot of uneven time constants that makes the lung appear functionally more stiff, and that's why the reactance curve is shifted over like it is. Next, please. If you look at patients with asthma on the left and patients with COPD on the right of different severities, you can see how the curves change in healthy versus mild, moderate, and severe patients. In the asthma patient on the left, on the top is the resistance, and you can see how those curves rise higher and become more curved, more frequency dependent. And the reactance curves down below shift down and to the right more and more as the disease becomes more severe. And you see similar patterns in the patients with COPD. Next, please. We do have normative values that have been measured. This is one of the best reference values that are out there, published by Ostveen in the ERJ in 2013. And what she did is look at men and women and looked at pre and post bronchodilator. So we have now some upper limits of normal for bronchodilation in resistance and reactance. And so we have some reference values that we can use in assessing whether these values are normal or not when they're measured by oscillometry. Next, please. So let's take the situation of a patient. This was a research participant we had whose pre-bronchodilator resistance was in blue. And notice it starts to curve up again, and that's because we went to pretty high frequency in this study. And their post-resistance is in the purple. And you can see how the purple curve is lower and it has less early frequency dependence. The question is this a bronchodilator response? I think you would say, yes, something changed, but how do we quantify it? Next, please. And based on papers that have been published and are summarized in a recent ERJ review from 2022, it is suggested that if R5 drops by at least 40%, or X5 rises, or in other words, becomes less negative by 50%, or AX drops by 80% in response to bronchodilator, that this might signify a clinically significant bronchodilator response. So I'm emphasizing the uncertainty here because we don't have a lot of data, but these are numbers that seem to be reasonable at the moment. Next, please. And here's another case of a patient that we saw as part of one of our studies who had long COVID. She's 71 years old. She presented with cough, wheezing, and dyspnea on exertion. She had normal spirometry, lung volumes, and diffusing capacity. And by spirometry, she had no bronchodilator response. But we did oscillometry on her. On the left-hand side, baseline, you can see the dark curves represent her resistance above and her reactance below. And the other lighter curves you see are the normal ranges. So you can see her resistance was elevated at low frequencies, and her reactance was markedly more negative than it should be. And the AX value was 76, and I can tell you that's a very, very high number. After bronchodilator on the right, you can see her resistance came down at 5 Hertz from 8.8 to 6.1. Her reactance improved from -5.4 to -2.3. And her AX got better from 76 to 19. And you can see the curves, how the resistance curve shifted into the normal range and the reactance curve shifted into the normal range. So when we quantified these changes down below, she almost met the criteria for an 80% improvement in the AX. She improved to 75%. And she did meet the criteria for an improvement in the X5, 57%. So if I were taking care of her clinically, I might think she does have some airway hyperresponsiveness, and I would treat her with at least bronchodilator and maybe bronchodilator and steroid to see if I could improve her symptoms. Next, please. Oscillometry has been used during methacholine challenge, and these are old data in a pediatric study. If you look at the bottom curve, that represents the FEV1 and the peak flow and how they slowly decline, with the FEV1 eventually reaching a threshold of a 20% fall at a certain dose of methacholine. If you look at the upper curves, that's resistance at 5 and resistance at 10 Hertz. And you can see how those numbers rise with methacholine, as you'd expect, more resistance. And the rise reaches a threshold of a 50% change about 1 dose sooner than the FEV1 fell. So this suggests that these measurements are more sensitive than spirometry. And also we might be able to shorten the methacholine challenge by at least 1 dose, which is good for patient and technologist as well. Next, please. So in summary, we've reached the end, and I know it's been a lot of information. I hope I've tried to demonstrate that spirometry remains the key to the diagnosis of obstructive lung disease like asthma. that we can use FeNO to reflect the eosinophilic inflammation, and this might help serve as a guide for additional diagnosis and therapy. And then oscillometry, an old technique that's finally commercialized and is becoming more prevalent, might be quite useful. It has a lot of an increased sensitivity to airway disease. It's very easy to perform because patients only need to breathe quietly. They don't need to do forced maneuvers. And we're gaining more and more experience with how oscillometry changes in disease states, so we might be able to use it someday diagnostically as well as to help guide therapy. That's the end of my formal presentation. Next, please. And so I'd like to thank you all very much for your attention, and we have plenty of time for questions.
Great, thanks, Dr. Kaminsky. Let me just transition over to the other slide deck real quick, but we will open it up for questions now. We have about a half hour allotted for those. Just while people are filling out some questions, Dr. Kaminsky, I'm curious because you work in a PFT lab, right? So you have familiarity with all these devices, but for someone who doesn't work in a PFT lab, or maybe their healthcare system doesn't have one, are there any recommendations on how they could get more expertise in, I'm guessing spirometry is the gold standard, right? So I'm sure RTs have a lot of familiarity with that, but for things like FeNO and oscillometry, are there any ideas or recommendations on how they could get more expertise in using these devices, or is it simply something that's, you know, they're gonna find in their PFT lab or in referring to someone at a PFT lab?
Yeah, that's a great question, Michael. You know, I think like with all things, experience is what counts. And so if you're thinking about getting a FeNO device or an oscillometer, try to seek out another hospital PFT lab that has one, and just see if you can spend, you know, half day or a full day with the PFT techs to learn the technique. That really is the best way, I think.
Okay, so I have some questions coming in here. Let me see if I can choose one of these. Bear with me for a moment here. There's a question from Jeffrey Haynes. He asks, can you discuss the role of SGAW for those without a FOT device? So SGAW for those without an FOT device.
Sure, thanks, Jeff, for your question. As Jeffrey knows, because we've talked about this, SGAW is specific airway conductance, and what it is another way to evaluate airway resistance. In fact, it's RAW, airway resistance, the reciprocal of that, divided by thoracic gas volume. So if you're doing body plethysmography and measuring lung volumes, most devices will automatically give you SGAW if you do panting as well as closed shutter panting. And so basically, SGAW is a measure of airway resistance. It's the reciprocal, so if resistance is high, we expect SGAW to be low. You could theoretically look at SGAW in a bronchodilator fashion. So in other words, give albuterol, you'd expect SGAW to improve. No one's quite really set a threshold for that, but some suggest that 25% improvement in SGAW might be clinically significant. And likewise, you could use SGAW as a measure of methacholine hyperresponsiveness. In this case, you'd expect the SGAW to fall, and some have suggested that a 40% fall in SGAW during methacholine challenge might be clinically significant. So if you don't have an oscillometer and you're doing methacholine challenge, you could add body box measurements to your spirometry. And Jeffrey and I and others have actually published a paper showing where we think we do pick up more patients with airway hyperresponsiveness by using this technique that we would have missed by spirometry alone. And there are various reasons for that. So I encourage you to think about that in your lab if you don't have oscillometry or FeNO, or you're just looking for other ways to increase the sensitivity of your methacholine challenge.
Okay, some questions are coming in. Thanks for those. So here's just a general question, I think. Carol Jones asks, like, the suggested order of testing. So if you start obviously with spirometry, where do you go next? And I'm assuming it has to do with the patient's symptoms, right?
Well, that's a great question. So if you're just doing conventional PFTs, spirometry, lung volumes, DLCO, you can start with spirometry. If you're doing bronchodilator, you can give your bronchodilator. While it's cooking, you can do your DLCO baseline because it's going to take 15 minutes or so for the bronchodilator to have effect, and we know it doesn't really affect the DLCO measurement very much. And you can squeeze in your lung volumes whenever. If you're doing oscillometry, theoretically, you should do the oscillometry first. And the reason is because it's so sensitive that even taking deep breaths during spirometry could bronchodilate the airways, or in some asthmatic patients, it could bronchoconstrict the airways. And so in other words, if you do spirometry first, that could influence your oscillometry measurements. So I would always do the oscillometry first and then the spirometry. Having said that, I think there's at least one publication that has shown not really a big influence of the spirometry on the oscillometry. So maybe it doesn't make a big difference, but theoretically it could. So I would do the oscillometry first.
Okay, here's a question from Jamil. She asked, can oscillometry be done at the bedside in the hospital? And she says, her comment is, I just realized I saw an order for it last week at my hospital, but none of my peers knew what it was. So thank you for this presentation.
Oh, that's funny. An order came through, huh? Okay. There is a billing code for oscillatory resistance. So some physicians out there might be catching on to that and might be ordering it. By the way, I hope they know how to interpret it. Okay. I don't want them just to be ordering it because they can bill for it. But in any case, the answer to your question would be yes. Right now, the devices are desktop type models, but one device uses a device plus hooked up to a laptop, so you could wheel that over on a cart to the bedside. And the other devices out there likewise typically sit on a desktop, so they could be put on a cart. I know there are a couple of companies working on portable handheld devices, which could be used both at bedside and also perhaps at home. So that's coming to be determined.
So here's another question from Jennifer. She asked, you talked a bit about patients that don't respond to bronchodilator therapy due to airway remodeling. For those patients, what kind of treatment options do you find helpful?
That's a great question. So first of all, I would never not give the albuterol just because they didn't respond in the lab. Because when we do lab testing, spirometry or even oscillometry, we're looking for changes, but that doesn't mean the patient isn't reducing their hyperinflation or improving maybe their mucociliary clearance or other effects of albuterol. So when you do bronchodilator testing, it's not to determine whether or not to give a bronchodilator. It's to try to help with diagnosis, and it's questionable whether it even does that anymore. So the answer to your question is I would still use albuterol, but I would mainly be focusing on therapies that will try to reduce progression of remodeling, and those are the inhaled steroids. By and large, those are the main drugs we have to help in that regard. Now, there are some early data using the biologic therapies that are out now, the anti-IL-5 therapies like mepolizumab and benralizumab, that those may help in reducing some airway remodeling too. So it remains to be seen if using those advanced therapies could help in that situation too.
Susan asked, could you discuss the role of FeNO in I'm just going to mispronounce this, non-eosinophilic asthma? Do you know the rough percentage of asthmatics that are non-eosinophilic? Sorry if I mispronounced that.
That's okay, non-eosinophilic, right. Well, I don't know the exact percentage. I think it varies depending on various populations you look at, but I think about 40 to 60% of adult asthmatics are eosinophilic, so you can assume around 40 or less percent, roughly speaking, are probably non-eosinophilic. And many of those are so-called neutrophilic, and then some of those are called pauci-immune, which means they just don't have a lot of immune cells if you were to biopsy their airways. So there are different types of asthma for sure. FeNO is really only sensitive to eosinophilic-driven inflammation, and so if you had a known non-eosinophilic patient, I would expect the FeNO to be normal.
Here's a question from Dan. He asks, with regards to oscillometry, which method do you feel is a more reliable measurement of resistance and conductance, either at a fixed or overlapping frequencies?
Okay, so now we're getting into some of the technical aspects. If you use a single frequency, you will get reliable information, but it only pertains to that frequency. So for example, some systems use 8 Hertz, and 8 Hertz is going to be reflective primarily of the larger airways, and so that's what you get. If you use multiple frequencies at the same time, and you can either do them, you can purposely use mutually prime frequencies like 5, 11, and 13 hertz, or you can have just a whole mishmash of frequencies all at once. When you do that, what you do is you gain some advantage in terms of understanding frequency dependence. So you can now see the curves of those lines with regard to frequency, which will give you information about heterogeneity. Also, you'll get a little bit of information about proximal versus distal effects. Now that I say that, a little bit of information, because the truth is we can't really get down to the very smallest airways unless we're well below 1 hertz. And none of the commercial devices go below 1 hertz. So when we say 5 hertz, that's a lower frequency, but it's still mostly larger airways we're picking up at 5 hertz. Remember, we all breathe at 2.2 hertz. That's our breathing frequency. So 5 hertz is way above breathing frequency. So I don't know if that answers your question, but there are slightly different advantages to using the multi-frequency versus single frequency.
All right, here's a question from Shauna about FeNO. She asks, is there a wait time to perform FeNO after spirometry?
Oh, that's a good question. Boy, I'm forgetting the details. Spirometry can slightly affect FeNO. FeNO shouldn't affect spirometry though. So if you're going to do FeNO, I'd probably, to be on the safe side, wait a short period of time after spirometry, but the other way around should be fine. You can do your FeNO and then you can do your spirometry.
Okay, a couple more questions coming in. Let's see. We use FeNO. This question's, I'm sorry, from Janice. So she says we use FeNO, however, we do not use bronchodilator as a challenge. Is there a benefit to this?
I guess I'm not 100% clear on the question. Does she mean looking at pre and post spirometry? Maybe you can ask that back.
Right. So, I mean, Janice, if you could submit another question with some more details, we could get that to Dr. Kaminsky about FeNO and bronchodilators. Let me move on to a question from William. He asks, in what clinical conditions does oscillometry make a critical difference in diagnosis or in efficacy of treatment? What clinical conditions?
Wow, I'm not sure I can answer that because we just don't know yet. Right now, it's hard to distinguish obstructive and restrictive disease with oscillometry, for example. Within obstructive disease, there are subtleties that you can distinguish between asthma and COPD. It has to do with intra-breath changes. In other words, it's so sensitive you can measure the changes in R and X even within a breath. So there are ways maybe to do that. As I mentioned, other diseases can cause abnormalities of oscillometry. So I think we're still in a huge learning phase right now. I would use oscillometry when either someone can't do spirometry or the spirometry is just not helping me and I'm not gaining any further insight from lung volumes or diffusion or x-rays or CT scanning or FeNO. I would try to use it as an additional tool to put together a picture that I think makes sense clinically. The problem is many diseases can cause elevation of airway resistance and many diseases can cause an apparent stiffening of the lung. So oscillometry, for example, can be abnormal just in obesity. So right now, we're still, again, learning how to position oscillometry in the clinical realm.
Okay, we have a few more questions here, but I would invite others to submit your questions because we do still have about 15 minutes or so remaining in our Q&A session. Let's see, this question here is from Cheryl. She says, adult providers are not as familiar with oscillometry. Even our pediatric doctors are somewhat challenged. What can we do to help increase their expertise and comfort with iOS?
Okay, first let me just clarify. iOS is one type of oscillometry, a specific brand. It's better to use the term oscillometry, just my opinion, okay? You're right, the devices are relatively new on the market. I think each of the companies is trying to provide education online in particular, also at professional meetings. There aren't courses per se that I'm aware of that just for oscillometry, although it is taught in some of the other courses on PFTs. There's a clinical guide that I mentioned before that you can read. There's also a detailed methodological statement that's been published. So it's hard. We're trying to disseminate this, we meaning the respiratory community, as much as we can. I know ERS put together a webinar series on oscillometry recently because my colleague, Dr. Charlie Irvin, was involved in that. So that might be something you can look into through ERS.
Okay, and that's all the questions that that our audience submitted. So I'd invite others to ask more questions if you have this for Dr. Kaminsky. We still have a few more minutes here. I didn't know, Dr. Kaminsky, if you wanted to revisit any of the material that you covered already, or any sort of overview, closing thoughts, anything like that.
Well, I'm just thinking about the other question that was asked that I wanted more clarity on. I think the question was, they don't do pre and post bronchodilator, but they do FeNO in their lab. And I think that's probably okay. We know that not all asthmatics respond to bronchodilator. We also know many patients with COPD do respond to bronchodilator. We also know that depending on the study you look at, having a bronchodilator response may or may not correlate with asthma control or symptoms or other endpoints. So it's quite questionable what bronchodilator response is telling us. Remember, it does not tell you whether or not to use bronchodilator for treatment. You should always use it in obstructive lung disease, especially if the patient says they get benefit.
I was just going to say, so Janice submitted a follow-up question regarding that one that you were just asking. She clarified, is there a benefit to using a bronchodilator with FeNO, or is it just for diagnosis of eosinophilic asthma and treatment therapy?
Oh, I see. Okay, I misunderstood. So I think you're saying, would you do FeNO like before and after bronchodilator? Is that, I assume that's the question then.
I think so.
And the answer is no. Spirometry can affect FeNO, like I mentioned. I don't think it's a large effect, but by and large, if you have an abnormal FeNO, the bronchodilator is not going to change it abruptly. The FeNO is reflecting underlying inflammation, whereas the bronchodilator is only relaxing the smooth muscle. It's not touching the inflammation per se. So I don't see that as being a benefit.
Okay, here's a question, another question from Jeffrey. He asks, would robust computer interpretation aid in the use of FOT?
Again, I need clarification on that. I'm not sure what Jeffrey means.
Okay, so Jeffrey, if you want to submit a revised question, we have another one we can go to in the meantime. Greg asks, can you speak to the efficacy of biologic therapies in patients that do not respond to Xolair and Dupixent responding to Tezspire?
Oh boy, that's a big question. Yeah, Xolair is anti-IgE. The other one you mentioned is anti-eosinophil. Tezspire is the new one that's against thymic stromal factor. I can't even say the name off the top of my head. Honestly, my experience with it is an N of 3 patients, and I have not seen a response in those 3 to Tezspire. However, data exist that are published that support using Tezspire as biological therapy in patients who do not appear to respond to eosinophilic biologic therapy. So I will still continue to try to use it in my practice. But again, I don't have very much experience with it. I think the data do support it, and in terms of the pathways of inflammation, it makes sense that it should be helpful.
Okay, I got some clarity from Jeffrey here. So I'm going to read his original question, and then he has an add-on to it. So the original question was, would robust computer interpretation aid in the use of FOT? And his follow-up was, instead of the physicians having to interpret all of the unfamiliar indices associated with FOT.
Okay, you know what? I missed the word computer. That's why I was confused,
Oh,
Jeff.
okay.
Okay. Sure, I think so. I mean, sadly, as we all know, AI has done pretty well in reading PFTs. There was that paper published from Europe a few years ago that showed the AI the machine learning algorithm did much better than the the seasoned pulmonologists. I cringed when I read that paper. But it makes sense because PFTs in general are all about pattern recognition. And of course, there are going to be patterns that are obscure, and the human mind is going to have to intervene to help with those. Certainly the same holds for FOT or oscillometry. There are a lot of parameters. They tend to fall in certain patterns. So I anticipate that machine learning or AI will help us with interpreting oscillometry in the future.
Actually, there is an exact question that just came in while you were reading that from William, and he's asked, do you think there's a role for machine learning / artificial intelligence in the interpretation of oscillometry, particularly as a diagnostic tool? So I don't know if you already answered that entirely, but there's an go with that, I guess.
I think there is a role for sure, yes.
Okay, here's a question from William. He asked, does oscillometry have a role in sleep medicine, particularly OSA?
Oh, that's a terrific question. Yes, it does. There's been quite a bit published with oscillometry. And in fact, a lot of it has to do with titrating CPAP. So you can imagine that when someone's asleep, you can apply the oscillatory signal at the mouth and measure airway resistance real time. And you could titrate CPAP and try to optimize its effect on airway resistance by reducing it. And there's a group in Europe that's published a lot in this area. So yes, that's a great question. The other area, by the way, that we may find it useful is in critical care. Oscillometry has been applied to mechanically ventilated patients, particularly those with lung injury. And you can gain a lot of insight into lung mechanics on the vent. And so there's a group from Iowa that's been publishing on this a little bit. And I can see the day where we might try to optimize our PEEP and other aspects of mechanical ventilation, rate and tidal volume, and even flow, based on trying to minimize respiratory system impedance. And again, this would work because you can send the signal through the tubing while the patient's on the vent and get a signal back and interpret it accordingly. So there's a lot of technical factors associated with that you have to be careful of, but there are data to support that approach.
Okay, that is all the questions that were submitted. So again, we still have a couple minutes, maybe time for 1 or 2 more. If anyone has anything else for Dr. Kaminsky. Oh, okay, here comes another one here. It's from William. Can oscillometry help diagnose induced laryngeal obstruction?
Yes, that's another area where it's been used. Vocal cord dysfunction or paradoxical vocal cord motion. As you can imagine, the signal is very sensitive to airway events, particularly large airway, and at higher frequencies, you'd easily pick up changes in resistance. And so it can be used that way. The problem with, and also intra-breath measurements can also pick up changes in vocal cord aperture if someone has vocal cord spasm or inappropriate narrowing of the cords. I was going to say the problem with vocal cord dysfunction in general is that it's a very evanescent thing. It comes and goes. And so unless you're making measurements at the time when someone has symptoms, you may or may not see it. But oscillometry would be a very sensitive measure for that.
Okay, a couple more just came in. One's from Carol. She asked, do you recommend oscillometry be part of regular PFT?
Oh, I don't know if it's ready for prime time just yet. Right now, I would say no, because I'm not sure we know enough to do what to do with the information. In other words, it's very sensitive, but it's not necessarily that specific for any one disease. And we're still learning a lot about how to interpret the results. So instead of just getting more data that we don't know what to do with, I'd rather stick with things we're more familiar with, like spirometry, lung volumes, and diffusion, and then save oscillometry as another test that we could use when things aren't making sense. Right now, that's the way I'm going to be approaching it in our lab, and I recommend approaching it in general. At the same time, we need more research, though. We need more studies to investigate how best to use oscillometry in clinical practice. I do envision a day when it will be used routinely because it's effort independent, and it can be used in a broader range of people, young children, people who can't do spirometry, etc. So I think when we gain more experience and knowledge about it, I can see that it might become a routine test.
Okay, two short questions remaining. So one's from Jeffrey. He asked, has FOT been used to measure nasal resistance?
Not to my knowledge, Jeff. I can see where it could be applied that way, but I don't know of any studies in that area.
Okay, and one more question here. This is from William. Is oscillometry, has oscillometry ever been used during exercise? I guess during CPET, possibly?
No, I know the group at UCLA was thinking of doing that, and they were running into some problems with signal, because what happens is, you apply very small amplitudes of flow at pretty high frequencies, of course, at the mouth, and it works during quiet breathing. But once you start breathing hard, it's questionable how well those signals will penetrate into the intrathoracic airways. Now, I don't know if they've overcome that through some method or not. There may be other groups certainly looking at this too. But as far as using oscillometry during exercise, I'm not aware of anyone being able to do that. Now, it has been used after exercise to pick up exercise-induced bronchospasm. In fact, there are studies that go way back using the forced oscillation technique to demonstrate exercise-induced bronchoconstriction. But again, during exercise, no, I'm not familiar with anyone doing that right now.
Okay, that's all the questions we have, and I think we're going to wrap up our program there. I'd like to thank Dr. Kaminsky for his time today, and also like to thank our sponsors today, Vitalograph and Thoracis. You can learn more about their spirometry, FeNO, and oscillometry products at their websites. Dr. Kaminsky, thanks very much for attending today.
You're welcome, Michael, and thank you too. I appreciate it very much.